Hey folks, welcome back to Rad Path Rounds. I'm Ryan Appleby, a veterinary radiologist.
And I'm Dr. Kate Baker, a veterinary clinical pathologist.
Kate, it's great to see you again. How are things?
You too. It's been great. I'm super excited to come back for another case collaboration. This is super fun.
I'm super stoked as well, Kate. And today we are looking at a 7-year-old male castrated lab cross who's presenting for vomiting and anorexia. And on blood work on presentation, this patient has hypoalbuminemia and thrombocytopenia. So, of course, as we do often, we are going to take some radiographs as part of our baseline diagnostic. And here we have both our left lateral and our right lateral projections of this patient. So if we take a look at the images, there are definitely a few things that jump out immediately to me. So take a second, look at them yourselves, and when you're ready, jump back in and I'll tell you what I see, which is that there is a loss of serosal contrast in this patient's abdomen. So when we're looking at the margins of our intestines and some of our other abdominal organs, the margins are not well defined at all. We can't see them. And that's because in this patient, we see evidence of peritoneal effusion. So all of these little wispy soft tissues, which sit here, especially superimposing the falciform fat, that is evidence of peritoneal effusion in this dog. So we've got peritoneal effusion in our dog. And when we look at the stomach, especially, the stomach is quite abnormal to me. So normally in our projections, we get a really nice gas-filled fundus in the right lateral projection and a gas-filled pyloric antrum in the left lateral projection. And that's partially true in this dog. But what we're also seeing is these lobular margins along the edges of the stomach. So best seen here in this right lateral in the fundus, but also present here at the dorsal aspect on the left. So there's something going on with the gastric wall in this patient. It's too thick. And this is not something we often see radiographically, but we certainly can in this patient. So we've got those findings in our lateral projections. And of course, no abdominal series is complete without a ventrodorsal projection as well. We've taken that and it confirms our findings here, where we've got this lobular soft tissue at the level of the gastric fundus, which is outlined by gas. So putting these pieces together, we've got lobular masses associated with the stomach and peritoneal effusion. Whenever I see that radiographically, the number one thing that comes to mind is cancer of some variety. So neoplasia is at the top of my list, but there are other things that can cause this as well. We shouldn't just, give a bad prognosis, a cancer prognosis based on this alone. We could have hemorrhage in the gastric wall. We could have granulomatous disease, or we could have gastric mural hypertrophy as well. Although these findings don't as well explain the peritoneal effusion as well. So we need to do a little bit more testing. And for us, that's some additional imaging. In this case, at my practice, we have access to CT, which is what we ended up performing in this dog. And so I'll just highlight quickly a couple of the CT findings. I know most of you don't have CT in your practice, but either ultrasound or CT are going to give us some really good information in this patient. We've got changes to the gastric wall, which is this organ here. So we've got our gastric outline here, and we've got portions of the gastric wall that are quite thickened relative to what they should be. This area here is also kind of a mass-like lesion in the gastric wall and along this margin here. And then the spleen itself is quite large, and we've got some lymphadenopathy in the abdomen as well. So I'm going to draw that very quickly. The stomach is this portion here. We've got some thickening of the gastric wall. We've got a big spleen, and we've got some big lymph nodes. So we've got multi-organ involvement in this patient. And when we compare what we were seeing radiographically, this undulating margin of the gastric wall radiographs, to what we see on CT, this is a dorsal plane CT image, we can see kind of a very similar finding where the wall itself has undulation of the margins, and then centrally we've got some fluid in the middle of the stomach. So this kind of confirms all of our findings, and of course we need to then get a diagnosis. And of course that's where Dr. Baker's going to come in. But when we compare all of our CT findings, we've got our gastric masses, loss of wall layering, expansion of the wall. We've got splenomegaly, hepatic lymphadenopathy, and a small intestinal mass that I didn't show you. So this helps narrow that differential list a little bit. We've got neoplasia, and because it's in so many different organs, I'm putting lymphoma at the top of my list, but it could be adenocarcinoma or something else. And then again, a granuloma or something is quite unlikely given that multi-organ distribution. We need to sample it. We're going to use ultrasound to sample these different organs. So this is an example of that small intestinal mass. And we would place a needle kind of like this into the small intestinal wall, do a fine needle aspirate, and then send those off to Dr. Baker for interpretation. So what'd you find, Kate?
Well, we had a very diagnostic sample, so good job on getting your sample. These can, I know, be challenging to aspirate when the intestinal wall is not very thick, when you don't really have tissue to exactly aim for. But in this case, we got a very nice diagnostic sample, and that is what we're going to take a look at. So here is a beautiful photo of the cytology from representative aspirate. And what we already can tell is that there is a lot of cellularity here, which is always a good thing in cytology. We want there to be cells there to look at. And like I said, sometimes we get samples in these cases that are not highly cellular, and that just may be a nature of the beast. Maybe the actual thickening or mass is not big enough and it can be difficult to hit. But in this case, we automatically have a lot of information in the cytology. And so what we're seeing here is we have to ignore just the blood in here. It's stained a little bit weird, so just ignore these kind of green red blood cells here in the background. But we've got this population of round cells here. So of course, when we're looking at cytology, we want to try to categorize populations as epithelial, mesenchymal, or round when we're thinking that we're dealing with a neoplastic population. And here we've got a population of round cells. So these cells have lymphoid characteristics. So I'll kind of describe what those are. They have just a little bit of cytoplasm. Some have a little bit more than others, but in general, they have a small amount of cytoplasm. Their nuclei are round, and you might notice that some of them have a little bit of a clear space right next to the nucleus. We usually associate that with plasma cells, but also large lymphocytes can have that as well. So that's an important thing to remember because that oftentimes throws people off. Other characteristics of these cells are very lymphoid. There's nothing plasmacytoid about them aside from that little clearing. So we have to remember large lymphocytes can have that, and that helps us not let that lead us astray. So we've got all of these cells that are large lymphocytes. And when we're looking at lymphoid populations, I've already told you that they're large lymphocytes, but you might be wondering, well, how can I tell that they're large? The reason we want to know whether they're small or large is because if we had a population of primarily small lymphocytes, that actually could just be lymphocytic inflammation. It could have been that you hit lymphoid tissue within the GI tract. That sometimes can happen. Or it could actually be small cell lymphoma, but we need extra testing to make that diagnosis. That's not something we make on cytology because it can look just like inflammation, small cell lymphoma, lymphocytic inflammation, normal lymphoid tissue, that can all look the same. But when the population is predominated by large lymphocytes, that's when we can feel confident that we're dealing with large cell lymphoma. And we like to use neutrophils, if we can find one, as kind of our internal ruler to gauge size of lymphocytes. So here in this field, we can see there's a neutrophil right here in the middle. And if you compare the size of these lymphocytes all around, you can see that they're larger than this neutrophil by quite a lot. And that's very important because if they were smaller, then we would call them small lymphocytes and we would go off on that track. But because these are all larger, they're large lymphocytes. And we really, when we're diagnosing lymphoma on cytology, we're looking at proportion of small to large lymphocytes. And if we have a predominant population of large lymphocytes, that's when we can confidently make the diagnosis of lymphoma. So here, wrapping that all up, we have a uniform population of large lymphocytes, which is diagnostic for large cell lymphoma. And this correlated very well with Dr. Appleby's findings on imaging and his suspicion on imaging. So excellent sample. Not so great for PUP, but we'll talk about that here next, kind of wrapping this case up.
Yeah, that is super cool. And I love that idea of using the neutrophil as an internal marker. We do similar things in radiology where we use internal markers to kind of help us either track lesions or even compare sizes of, say, the intestinal tract. That's super awesome and something to consider in lots of aspects of veterinary medicine. And I'm going to keep that in mind the next time I'm looking at a little sample on the clinic floor, making sure I got enough cells for you. I'm going to see if I can compare a lymphocyte to a neutrophil and see
Do
what I
it.
see. That's cool. All right. So, as Dr. Baker said, large cell gastrointestinal lymphoma, not the best diagnosis for our patients. So these have a poor prognosis in dogs. This is a nice article from JAVMA in 2018 that looks at intestinal lymphoma in dogs, 84 cases, so a nice population size for them. They found that overall mean survival time was only 62 days. So unfortunately not very far. And then there were shorter survivals with both anorexia, abdominal lymphadenopathy, and other organ involvement. And so we're distinguishing the intestinal lymphoma from that multicentric lymphoma when we have peripheral lymphadenopathy. So that's a distinguishing feature that we're doing here. But if patients are moving forward with therapy, the treatment of choice is going to be chemotherapy, and not for this patient, but if it was a localized mass, there could be surgery to remove that mass from the intestinal tract. Of course, that's going to be location dependent and not as helpful when there's so many lesions as it is in this case. So, that's the information we have for you on lymphoma. And if you're interested to learn a little bit more about veterinary oncology and thinking about some of the different common diseases that we see in dogs and cats, and some of the different treatment options and prognoses, we've got a course on obvet.com. If you go to obvet.com/sources/courses/oncology, you'll be able to find that. And Dr. Chris Pinard will take you through a number of interesting things. But this has been super fun, Dr. Baker. Thank you for this awesome case.
Yeah, as always, I love seeing the correlation between imaging and cytology. So very cool case. Again, we always say cool in the diagnostic world. We recognize that not great for the pet, but it is just a really great learning case so that we can better help patients, and we have a diagnosis here so that patient can get some further treatment. So yeah, great case. Thank you for sharing your part of it.
No, perfect. So thank you. And I look forward to doing this again soon.
Yes, as do I. See you next time.
All right.